Thank you, Alexandra. It's really an honor for me to participate in this Congress. As you just said, we go back a long, long way, specifically fighting to implement MRI as a very indispensable tool in breast cancer treatment. And this is actually the aim of my talk, to convince you that MR should be used in all breast cancer treatment de-escalation techniques and procedures. In the evolution of breast cancer surgery, the results of prospective randomized trials have shown that less surgery is just as efficacious as more surgery. The Holsteinian radical mastectomy concept gave way to the modified radical mastectomy and eventually partial mastectomy. Likewise, axillary management began as a complete axillary dissection and has subsequently been superseded by sentinel lymph node biopsy. The historical progression of breast cancer management demonstrates the breast surgeon can perform less surgery provided the extent of local therapy has no impact on overall survival. Current breast cancer researchers are continuing to seek less invasive, less morbid alternatives while still achieving equivalent outcomes. And as I said, my aim in this talk is to show that all breast cancer treatment should be image guided, especially in this new and exciting era in which breast imaging has become sophisticated, as the talks of my two previous colleagues just showed us. And from my point of view, we are now able to assist in the current trend of treatment de-escalation, always through a multimodal approach, integrating diagnosis and interventional techniques. There are three main clinical scenarios in which breast imaging, specifically MR, can contribute to de-escalate treatments. The rationale supported by ongoing trials, as I will show you. But I would like to start with omission of surgery in complete response after neoadjuvant chemotherapy, because it shows how important it is to use the full potential of breast imaging techniques, always integrated with our interventional skills learned after years and years of performing minimally invasive vacuum-assisted biopsies and excisions. I call it a cautionary tale, and I will explain to you why. In defined breast cancer populations, the use of chemotherapy and multiple targeted treatments has progressed to the stage that it is appropriate to question whether surgery is now a redundant procedure in their management. In this 2003 editorial on the feasibility of breast-conserving surgery in patients treated with neoadjuvant chemo, the authors from the University of Aberdeen asked, is surgery still necessary in patients with a complete clinical response to chemotherapy? Their answer was yes. But once there is a technique for accurately identifying those patients who do not have any tumor remaining following completion of primary therapy, then again, there's the possibility of selected patients not requiring what are often major surgical procedures. 10 years after that editorial, 10 years after, these authors from the University of Birmingham described the key improvements in neoadjuvant therapy that have resulted in the need for routine surgical treatment for some early invasive breast cancers to be re-examined. Developments in systemic neoadjuvant chemo have progressively increased PCR, and recognition of the importance of pathological subtype in predicting in PCR facilitates identification of subgroups with very high PCR rates. So is surgical management keeping up with the times? Indeed, approximately 20 to 40% of patients with primary breast cancer undergo neoadjuvant chemo with or without anti-HER2 treatment. Depending on tumor biology and stage, about 35 receiving neoadjuvant treatment achieve a pathological response. But novel treatments have shown PCR rates of up to 80% in patients with triple negative cancers and up to 70% in HER2 positive cancers. These are internal data from an analysis I performed in 29 of our patients. And yes, they achieved a 65% complete response rate. And on the other hand, it was interesting to see that we had, if we compared the MRI data, the MRI response with the pathology response, we had an exact correlation in 76% of our patients. We had an overestimation in 3%. There was one patient. That means we've overestimated response in one patient and underestimation in 21% of the patients. But the correct PCR detection rate was 92%. This is good news. This landmark paper published in 2017 analyzed the initial results and the ongoing trials in the omission of surgery after neoadjuvant chemo in patients with complete or near complete response. In this 2018 analysis of possible de-escalation scenarios in surgery, the surgeons claimed that minimally invasive based resection technology along with targeted tumor ablation will rapidly progress. It is critical that surgeons have these imaging skills so that they can perform these procedures. Initial single-center trials using vacuum-assisted biopsy yielded promising results. This is some slides of presentation I presented actually in Athens in 2018, where I tried to summarize all the trials that were completed at that time from the MD Anderson, Heidelberg from Germany, and from the UK. Only 2 of them achieved a false negative rate of 5%, of 0% if vacuum was used. But as you can see, none of them used MRI. And in 2 of them, a false negative rate was really high, 22 and 26%. Ongoing trials at that time were at the MD Anderson. In this case, they did not do surgery before. They went directly onto radiotherapies, as I will show you in a minute. Then in this Netherlands, they did core needle biopsy, which is, in my opinion, and I think we all think that we should go for vacuum-assisted biopsy. And in this case, the responder, Heidelberg Multicenter, they did not use MRI. Those were their endpoints. We'll see what happened. This is the MD Anderson trial, where they did not operate on the patient. There was no residual disease after vacuum-assisted biopsy. They went on to radiotherapy alone and no surgery. The future trials at that moment were one from Birmingham and one from the States. And at this moment, this one is recruiting, but this one has been suspended due to the bad results and due to the fact that their endpoints were not reached. So recent subsequent confirmatory multicenter trials could not reach their primary endpoint, the ones I showed you. Compared to standard breast surgery, vacuum, also corneal biopsy, showed high false negative rates from 18 to 50% in all these studies, which we'll see in a minute. These are the studies. As you can see, this is the only study performed by radiologists and with vacuum under MRI with a false negative rate of 10%. In the rest, performed under mammography or ultrasound, not using MRI. Here, using MRI in some of the cases, but using core-needle biopsy, false negative rate 50%. In this one, core-needle biopsy also, and plus vacuum. And in some cases, MRI, but it wasn't really detailed in which cases they used MRI. False negative rate of almost 20%, false negative rate of almost 40% in this one with core needle biopsy. And this one didn't show results, but they used mammography and ultrasound. This is an interesting Spanish ongoing study, which I want to show you because they are only doing it in HER2 triple negative tumors. And they use MRI in all cases. And the preliminary results are really very encouraging, a false negative rate of 5% and a negative predictive value of 94%, although it's only 20 patients. But I think they're very encouraging. Due to this discouraging data, which I showed you from the surgical studies, the group of international surgeons involved in these projects decided to sit down and analyze what had happened and what factors had contributed to the bad results. In this case, they did a multivariate algorithm to select among these 457 patients what had failed. They did what they called an intelligent VAB, the use of multivariate algorithms, which incorporated all the variables. And in this case, they did a multivariate analysis and they concluded that DCIS, multicentric disease, and clip markers should be removed during vacuum, something that we, of course, take for granted. What struck me when reading their analysis is the small role the imaging techniques played. Imaging showed vague definitions, either US, mammography, or MRI, with no diagnostic criteria, no definite diagnostic criteria. And by contrast, pathology had to be evaluated by a board-certified radiologist. Vacuum interventional techniques did not include MR guidance. Of course, we don't need MR guidance in all cases, but in some cases we do. And the representativeness of the cause was left to the subjective assessment of the biopsying, whatever that is, physician. And there were no words at all on checking if the clip was correctly positioned in order to establish radiopathological concordance. Of course, pathological evaluation, again, evaluated by both certified pathologists. In this chart, it seems that they suddenly realized how important it is to combine imaging plus VAB, and that it would have led them to fewer false negative rates. This proves that they did not adequately integrate both sides of the equation from the start. Vacuum after neoadjuvant chemo for non-operative management, the response evaluation should be performed with the best, albeit not perfect technique, and that is MRI. And we also should take into account the factors, the MRI factors that influence the accuracy of the technique in order to assess which patients might benefit or not from vacuum. We know that MRI is by far the best and the most accurate technique compared to clinical exam, mammography, and ultrasound. And we also know that there are some factors like the type of baseline MRI lesion, the tumor subtype, type of radiological response, definition of PCR, does it include or not include DCIS, and the type of treatment. And there are many challenges to implement vacuum post-NAC treatment, of which I would like to remark here the selection criteria. as the starting point they should be based on imaging features, in my opinion. So vacuum, also what we learned from the publications is that vacuum didn't always include the clip. Core needle biopsy should not be allowed at all. And post-vacuum, clip location should be checked. Vacuum should be performed by experienced physicians, maybe radiologists. We do it every day. And always take into account imaging data correlated across all modalities, as well as radiopathological concordance. So close collaboration between radiologists, surgeons, and pathologists is, in my opinion, the only way to go. Another clinical scenario, which I would like to comment briefly, is the omission of surgery in early breast cancer. We will talk about the small trial and the MiniVAB trial. Minimally invasive techniques can potentially reduce the complications and morbidity associated with standard treatment. They are probably more cost-effective. Operating room costs versus outpatient procedures are clearly more elevated. Vacuum is also widely available. This is a standard of care in BI-RADS 4 and B3 lesions. And vacuum, we know that we can successfully excise most of the lesions. Some people say 90% of the cases. It really depends, but in a very high percentage of cases. Here's a case of a patient with a previous contralateral cancer where we found with contrast-enhanced mammography this very small tumor. This was a contralateral recurrence, which was 4 millimeters. We did a vacuum in order not to miss anything, because this was difficult to target with core needle biopsy. We didn't do an excision in order to avoid surgery. We just wanted all the tissue as much as we could get. Turned out to be an invasive ductal cancer. And here you can see that in the post-vacuum, there's no residual tumor as pathology showed. So that means we are able to do it. If we do it carefully and image guided, we are able to perhaps excise very small lesions. In this chart, I will show you what's been published about minimally invasive treatments in breast cancer, although only these, in this case, we have only breast cancers, which this is from the group of Ritzaman, in which they used BLES. But unfortunately, although they used MRI in 11 patients, none of the BLES excisions were adequate. And this is why he has moved on to vacuum-assisted biopsy. In this case, in the rest of the cases, MRI is not always used, and this also used BLES. And as you can see, the residual disease is very, very high. The small trial is a prospective multi-center randomized trial, phase 3 trial, with 800 patients over a 4-year period, primary outcome, re-excision rates, and local recurrence, free survival time, secondary outcome, psychological impact of vacuum compared with surgery. That's interesting, and very, very interesting cost effectiveness analysis. No sentinel lymph node in the vacuum-assisted excision arm. But unfortunately, and in my opinion, this is the only but I give to this trial: no MRI to stage or follow the patients up. Because as we know, and as our dear Tibor Todt says in this paper and shows in this paper, and all those who do breast MRI for preoperative staging know it very well. If you analyze initially unifocal invasive breast cancers, a great percentage of them have separate foci. And the size of these foci is about less than 10 millimeters in 93%, but they are there. And they occupy an area which is fairly large in 1/3 of the patients. So unifocal cancers should all be analyzed with an exquisite technique that takes account of all these multifocality if we don't want to fail. As in this case, we initially saw this HER2 tumor, which was initially detected actually by ultrasound. But when we did the MRI, we could see that there was extensive DCIS accompanying the tumor. It was proven by breast MR guided biopsy. The MiniVAB trial does use MRI, and it will be done in cancers less than 1.5 centimeters, 170 patients, taking into account that 7,000 of women in the Netherlands have T1 cancer. Excision will be followed by surgery 3 weeks later, and the expected complete excision rate will be 70%. The authors, this is Ritzeman, is the leader, the IP. Success if no more than 4 millimeters of cancer in the surgical cavity specimen is continuous with the biopsy cavity. This is because the Dutch guidelines accept this as an acceptable recurrence risk. And the third clinical context, and very interesting, which I would like to show you, is the prospect trial. We know that radiotherapy has side effects, moderate to severe, chronic adverse effects in up to 1/3 of patients. Even using high-end and very sophisticated radiotherapy methods, 12% of patients have been reported to have poor prognosis at 5 years. And it also increases the rates of major coronary events by 7.4% per gray mean heart dose, with the absolute risk of radiation-induced cardiac toxicity increasing substantially in patients with pre-existing cardiac risk factors, especially women over 70 years. There are some studies that already show that, for instance, the CALGB 9343 study, that in older women with early ER-positive breast cancer, avoidance of adjuvant radiotherapy was a reasonable choice because there was no change in overall survival. Recent clinical trials like the PRIME-2 support de-escalation of adjuvant radiation in low-risk hormone receptor positive, less than 3 centimeters negative lymph node breast cancers. The adoption of these findings into clinical practice and the effectiveness of de-escalated therapy in real-world populations still remain under investigation. And there are opportunities to improve care delivery by focusing on which barriers stop the implementation of de-implementation of routine use of radiotherapy. And I think the buzzword here is better patient selection. Better patient selection. How? Cancer treatment has entered the era of tailored medicine, which may be personalized to the individual and may stratify patient groups of similar risk. There are basic clinical pathological parameters that are being enhanced, and those are the ones we use in our everyday clinical practice, but we know that they are being superseded by tumor genotyping. And though these techniques are incredibly helpful, they are also expensive. And some people think that, for instance, immunohistochemical biomarkers can help. This is I will show you in a minute, the prime time study in which they use IHC4 plus, which is combines protein expression of estrogen receptors, progesterone receptors, HER2, and Ki-67 with clinical pathological parameters in order to identify patients with a low risk. This is the chart. The primary endpoint is ipsilateral breast disease at 5 years. And they would be happy to get a local relapse rate of 4% in 5 years. But this is another interesting study, which is based on the use of MR. It's directed by Bruce Mann, who is a surgeon, and by Alison Rose, who is a radiologist in Melbourne. The hypothesis is that MRI can detect the lesion successfully treated by radiotherapy, and wide excision alone is sufficient for those with unequivocal unifocal low-risk cancer on MR. The aim is to see the rate of local recurrence, and this is the patient population, more than 50 years, invasive unifocal cancer, less than 2 centimeters, not triple negative, no extensive intraocular component, no lymphovascular invasion. And criteria in MRI they include nil, or minimal or mild BPE on MRI, and unifocal cancers. The primary endpoint, which has been reached, they will be published soon, is ipsilateral invasive recurrence rate at 5 years. And then there are secondary endpoints. This is the study accrual. Out of 443 screened, 2,201 were eligible. And I just want to show you that in the eligible group, there were 22% occult lesions. In the ineligible group, there were 43% occult lesions, which mean lesions that only MRI showed. And the malignancy rate of those occult lesions was 38% in the ipsilateral breast and 42%, almost half of them, in the contralateral breast. This is to show that the BPE by age was mostly minimal or mild in all age groups. And depending the breast density, as can be expected, it is less limiting in BI-RADS A and BI-RADS B patients. So BPE played a very important role in the selection of the patients as the cause of ineligibility in 40% of the patients. Primary analysis is complete. Should the results support the hypothesis, further trials will be needed to confirm and extend the findings, to see what inclusion, if they can be modified, and the radiological procedures. So the implications of prospect, and this is my before last slide, is that opportunities to improve care delivery by focusing on barriers to, as we heard this sentence before, are based on better patient selection. And the results of prospect suggest that many local recurrences are due to occult breast cancers. And MRI can truly identify localized cancers, which are really localized cancers for which radiation may be safely omitted. Identification and treatment of occult malignancy in an apparently unifocal early breast cancer is beneficial. So exhaustive radiological analysis of occult lesions is the selection we need in order to de-escalate radiation therapy and perhaps surgery. And I can tell you that preliminary results of prospect, which are already out there, but they will be announced very soon. So stay tuned. So in conclusion, minimally invasive excision of residual or early breast cancers should be a joint effort in which radiologists start the process by a thorough selection of the candidates and an efficient use of vacuum-assisted excision across all modalities. Due to its proven high sensitivity for multifocal disease, breast MR should be mandatory in all de-escalation projects. In order to stratify and select the patients correctly, we need to engage more with surgeons, oncologists, and radiation therapists in order to participate actively and perhaps lead the way in multicentric trials where our expertise is rightly appreciated. Thank you very much.
Thank you.
I'm sorry, I just went 4 minutes past the time. Sorry about that.
No problem. Thank you for this really insight into the future lecture, and thank you for nicely presenting all the ongoing trials and the prospective idea of how we can even be more implicated as breast radiologists in the tailored treatment. And we shall conclude the session with comments and discussion from our breast surgeon.